All right, let's dive right in. Today, we are tackling something incredibly serious, a real high-stakes medical situation. We're going to break down the protocol for a hypertensive emergency during pregnancy.
So, put yourself in this situation for a second. Imagine you're a first responder, and that call comes in. Your patient is pregnant, and things are going south fast. You've got minutes, maybe even just seconds, to make calls that could literally save 2 lives. So, what do? Well, that's what this protocol is all about. It's the roadmap for that exact terrifying scenario.
Okay, so first things first, let's really get a handle on what this emergency even is. What are we actually talking about when we say a hypertensive obstetric emergency? So, at its most basic level, we're talking about a sudden, super dangerous spike in blood pressure. And listen, this isn't just a little bit high. No way. This is a massive surge, one so severe that it can cause seizures, organ damage, truly catastrophic stuff for both mom and baby. It is a full-blown medical emergency, no question about it. And here's something you might not expect, the time frame we're looking at. This protocol isn't just for patients in the later stages of pregnancy, after 20 weeks. It actually extends for up to 6 weeks after the baby is born. Think about that. It just goes to show you that the danger doesn't just disappear the moment of delivery. All right, so let's move on to reading the signs. When a first responder shows up, their first job is to be a detective, right? They have to size up the situation in a flash by looking for clues, both what the patient is feeling and what their history tells them. A lot of times, the patient's body is practically screaming for help. We're talking about a really bad headache that just won't quit, maybe seeing spots or other weird visual changes, or sudden swelling, trouble breathing. These aren't your typical pregnancy aches and pains. In this context, these are huge, flashing red lights, urgent alarm bells. And while they're checking for those physical signs, the responder is also gathering intel. Quick questions, right? Do you have a history of high blood pressure? Have you been getting prenatal care? Any complications in other pregnancies? Every answer helps build a risk profile on the spot, giving all that physical stuff some much-needed context. So all of this, it brings us right to the heart of the protocol. After piecing together these initial clues, the responder hits a fork in the road, a really critical decision point. And this, right here, is why having a clear, step-by-step plan is absolutely non-negotiable. And what's the very first action? It's always the same. Before you do anything else, you get the hard data. The protocol is super clear. Measure the blood pressure, then wait 15 minutes and measure it again. This is all about making sure that a high reading isn't just a one-off fluke. You've got to confirm it's a persistent, dangerous problem. Now, this is where it gets really interesting. The protocol lays out 2 distinct paths to immediate action. And get this, you don't need both. Path A is all about the numbers. If blood pressure is crazy high, over 160 systolic or 110 diastolic, that's your trigger. But then there's Path B, which is just as serious. That's when the blood pressure is elevated, maybe not sky high, but the patient also has those warning signs we talked about. The headache, the vision changes. Either one of those paths means go time. You start treatment, and you start it now. So let's zero in on that first number for a second, 160. That's the systolic pressure, the top number. It's the force inside your arteries when your heart is actively beating. A number that high, it means the heart is working against a ton of resistance. It's putting an incredible, dangerous strain on the whole system. We're talking the blood vessels in the brain, the placenta, everything. And that bottom number, 110 diastolic, is just as scary. That's the pressure when the heart is supposed to be resting between beats. If it's that high, it means the blood vessels are under constant pressure, with no chance to relax. It's a huge red flag that organs, especially the kidneys, could be getting damaged. Okay, so the moment one of those triggers is hit, the game changes. We shift from just assessing the situation to taking action. There's no wait and see. The plan lays out exactly what you need to do to protect both mom and baby. For those really severe cases, the ones on Path A, the main goal is obvious. You've got to get that blood pressure down. But, and this is a big but, you have to do it carefully. If you drop it too fast, that can be just as dangerous. You could actually cut off blood flow to the placenta and hurt the baby. So the protocol gives you a controlled, step-by-step way to do it right. And this is how they do it. The go-to medication is labetalol. Why? Because it works fast, and it's effective, but it doesn't mess with the blood flow to the uterus, which is crucial. So you give a first dose. Then, and this is key, you pause. You wait 10 minutes, and you check the blood pressure again. Still too high? Okay, now you give a second, bigger dose. It's this simple but brilliant little loop. Treat, then reassess. Treat, then reassess. Now, there's another really important medication, and this one is for patients on either path. It's magnesium sulfate. And here's the thing, this drug isn't really for the blood pressure. Its main job is to protect the brain. It basically calms down the central nervous system to help prevent seizures. Those seizures are called eclampsia, and they are absolutely life-threatening. So this is a vital protective shield, if you will. And while the meds are being given, a bunch of other stuff is happening all at once. The patient is getting oxygen, vitals are being watched like a hawk, and they're positioned on their left side. Ever wonder why the left side specifically? It's pretty smart, actually. It takes the weight of the uterus off a massive vein, which helps improve blood flow back to the heart, and most importantly, to the placenta and the baby. So the first round of interventions is done, but the crisis is far from over. Now the next phase begins, getting the patient safely to where they can get more advanced care.
You see, getting the patient stable on scene is really just the start. During that ride to the hospital, the responder can't let their guard down for a second. They have to keep reassessing, keep watching those vitals, looking for any tiny change in the patient's condition.
And that leads us to the final piece of this puzzle, getting the patient to the right destination. We're not talking about just any ER. We're talking about a center that specializes in high-risk obstetric emergencies. And really, that's what this entire protocol is built for, to stabilize the patient just enough so they can safely make that critical journey. So when you think about it, it all comes down to this, right? In a situation that's pure chaos, where stress is through the roof and time is ticking away, your gut instinct just isn't enough. A protocol like this takes all the guesswork out of the equation. It hands you a clear, proven plan. It turns an overwhelming crisis into a series of calm, manageable steps. And really, in that moment, what could be more powerful than that?